So good evening to everybody. I have two talks. One is on ECPR, the extracorporeal CPR, and one is on ECOR, the extracorporeal CO2 removal. Now we start with the ECPR talk. Now it's a very popular term nowadays, and people is using this ECPR in a very it was not a very common thing where we have started ECMO 10 years back. But nowadays, almost every ECMO institutes who are practicing regular ECMO, they have regular ECMO programs that are doing this ECPR. Now, as you know, this is a basic diagram of the ECMO, and mostly we know three types of ECMOs we see. One is VV, VA, and hybrid one. Now, in ECPR, it is the rapid deployment of veno-arterial ECMO to provide circulatory supports in patients in whom conventional cardiopulmonary resuscitation is unsuccessful in achieving the sustained return of spontaneous circulation. So this is the way when you are doing ECMO while ongoing CPR. That is the idea of ECPR. And when the conventional CPR is failed and the patient has not been able to get a sustained ROSC, that's where the ECPR works. Now, if I start with a case, this lady actually came to the OPD with orthopnea for last 3 days and the fever for last 1 day, and suffered a cardiac arrest there in the OPD. Cardiology OPD suffered a cardiac arrest, and CPR being initiated by the bystanders, the hospital employees, called for assistance and immediately shifted to ER, where she got intubated and ventilated with ongoing CPR, taken on inotropes. Somehow the ROSC achieved. But the case didn't stop here. So got a rapid recurrent VF, CPR restarted, DC shock given. Intermittent ROSC achieved after 7 to 8 minutes of CPR, but recurrent VT was ongoing. Then the ECMO team being called because of the recurrent cardiac arrest. And just checking with the thing, this heart looks like this. If the video runs, there's a severe LV dysfunction with LV is very dilated. And the ECMO team started working when the patient is having recurrent LV dysfunction. If you can see the heart is really standstill kind of thing. And there is not much of movement seen in the heart. Now the question is whether rescue is possible in this scenario or not. Now, American Heart Association guidelines, this extracorporeal CPR in patients refractory to standard ACLS training is considered to be a class 2A evidence. And so in this patient, what we have done, we cannulated for VA ECMO in the groin, and the puncture was a bit higher up, and later on we put a distal perfusion cannula while ongoing CPR, and ROSC achieved after putting her on ECMO. Now, just after putting the patient on ECMO, this is the X-ray, and this is the ABG, show that the lactate is 10, then gross acidosis, pH of 7.105. And if you see the situation, usually the situation is like this. The patient is having ongoing CPR going on. and we are cannulating at that point of time. So this is the usual scenario of a ECPR situation. Look at the CPR is going on, continuous CPR going on, and we're cannulating in the groin. The ECMO specialists are making the priming the circuit, and after the cannulation, it will be connected to the ECMO circuit. This is the usual scenario. The patient has been taken to ICU and had a cardiac arrest, and the ECPR is going on. They're doing cannulation. They're changing the hands to continue the CPR. The heparin and is drawn, and we have to give a liberal heparin dose at 1 mg per kg after the cannulation is over. During the CPR, the continuous during ECPR, the cannulation, the CPR is going continuously. So you can take the help of the Lucas, that is the automated CPR machine, but we don't have that. We continued the CPR by changing hands. It takes 15 to 20 minutes of cannulation and to connect to the ECMO machine. My cannulation is over and we are connecting the the CPR has to be continued till it is connected with the ECMO machine. After some time, after 2 days, the X-ray looks like this with little bit of clearing. Your ABG started improving. The lactate came down to 6. Acidosis got corrected, and you continuing on ECMO flow. And the saturation was 72 to start with because of the massive pulmonary edema, but the flow we have achieved around 2.37, and we are getting some amount of ejections also. We continued over there. The patient started improving. The acidosis got corrected. The saturation is coming up with the clearance of the fluid from the lung, and you can see the heart has started improving. The contractility has started improving a bit than the before. Heart was not moving. Now, if you see the reports, you can see the SGOT and SGPT are pretty high. 5,700, 3,300, and it's coming down slowly over the day, and is getting normal. The shock lever is getting normalized, and urea creatinine also started jumping, but it started coming down. And this is the thing after 4th day of ECMO thing. Look at the heart. The kind of LV has started improving, and the X-ray is almost getting clearer. The pulmonary edema has got almost cleared up, and it has started improving in the saturation and the hemodynamics. Now, on day 6, we started coming down on the flow From 2.37 flow, we came down to 1.88. Looking at the blood pressure, looking at the pulse pressure, looking at the echo, how is the LVOT VTI is going, how is the your TAPC is going, the right heart, it has came down to 1.3 liter. Then looking at the monitor, how the blood pressure is maintaining, the periphery is getting colder or not, the saturation, the lactate, and then come down to idle flow of 0.8. Now, this is the rapid trial off we did, the clamp, and the did an ABG, which shows this is the lactate is 1.29 with the FiO2 of 40%. We are getting a 81 PO2. That means the lung is well oxygenating. Your monitor shows the saturation of 100, heart rate is not much, 70, and the pressures are good. And then you call the surgeons to for the decannulation. As I told you, there's a high up puncture, so we have decannulated uneventfully. And patient actually improved after that. We extubated this guy. Now, what do we do when they face a similar scenario? So CPR followed by a single clean established puncture in the femoral axis as soon as the ROSC achieved, or if not achieved, you have to take the puncture in the arterial. Venous is easier to get. Now, if your institution is an ECMO center, then neurologically is okay, consider for ECPR. If not, then consider the conservative management and prognostication the relatives. Now, what to expect when you are doing the ECPR? There is mostly the features of hypoperfusion, the tissue injury, the lactate rise, organ dysfunction. These all four things happened in our patient. We have seen the liver is not doing well and then started coming down in the liver enzymes. The creatinine went up and there is coming down, and the lactate also settling. Now, feasibility is mostly of this 4C, the cost. Who will give the cost, because the patients are not prepared, relatives are not prepared for this cause. For what you are putting is a reversible cause, it's a young guy, or it's a irreversible cause. Cannulation, who is goes to lead the cannulation during that kind of scenario where the pulse is not palpable in the cardiac arrest, who is going to give the CPR also. The cannulation, the guy, and the continuity, how this continuity, how the brain will function is after the CPR is over, and whether the patient is getting awake or not, and the other organ functions. Now, our patient actually improved a lot after taking out the ECMO, and she started getting better, and we discharge her after, say, 2.5 weeks. Now, if we go back to the literature, that is the systematic review is current ECPR protocol has been told in a step towards standardization. This, the root cause analysis shows that percutaneous cell linear with USG is the best method where you actually can puncture the vessel at that point of time during the ongoing CPR. And there are 3 trials which shows the ECPR. There's the arrest, Prague OHC, and the inception, the time on the scene, the transportation, and the cannulation. So most people preferred, these are the OHCA trials, most people preferred go to the site of cardiac arrest and do cannulate, just reduce the transportation time, and then transfer after stabilization on ECMO. Now, looking at the distance, what to do, load and go, minimize the time on the scene. The proximity to ECPR center will keep the transportation time short. On-site cannulation, that is one option that I told you. Long transportation times can be avoided. Cannulation might take longer because the on-site may not be in your controlled environment. The regius in initiation hospital, take the patient, ongoing CPR, and then coming back to the original hospital, or the ECPR enabled hospitals. Everything has its own issues, but these are the problems. What we whether to get the readiness for the ECPR is the whether we are doing the out of hospital cardiac arrest or not. The patient selection, age should be less than 75. Bystander CPR should be started and should be good quality. Shockable rhythm is usually a very good outcome. Short, low flow duration, incomplete information, professional CPR teams is there or not, availability of ECPR resources. That is for the patient selection. Logistics, integration of ECMO center, where to cannulate, that is one thing. On ICU, any trained staff, bleeding, transfusions can be managed, thrombosis can be managed, or 24/7 availability or demand. Ethical dilemmas are one of the major hindrance. Care is stressed to the team or neuroprognostication if the patient is not getting awake. Cannot cannulate, complications are there. It could not cannulate the mostly the arteries. CPR associated with the trauma, the broken ribs, the pericardial effusions, leg ischemia, we could not cannulate the distal perfusion, bleeding, that is one of the most common complications. ECPR transition, availability of ECPR resources, transition of minute, and preclinical integration of ECPR. You need to have it, all this thing in the same bucket, and then you can run your ECPR program in the out-hospital cardiac arrest. To start with, you should start in your hospital. You can categorize the territories, probably start with the cath lab, probably start with the operation theater, then in the ICU, then go to the emergency. So better to start your ECPR program wherever you are comfortable and you can do maximize your skill set. Now, rationally for ECPR is however, even with optimal technique of CPR delivers a 15 to 25% of the cardiac output, ECPR actually gives a good amount of cardiac output support, at least 60 to 70% support in comparison to conventional CPR. Now, 4 distinct intervals of CPR. I know that's the witness bystander CPR with arrest, with the bystander CPR, shockable rhythm, no major corporeality, ETCO2 or lactate. Then failure of conventional CPR to achieve ROSC. The EMS should be there. The cannulation and establishment of ECMO support, insertion of distal perfusion catheter. Attempt should be go on to ECMO flows from 30 to 60 minutes of low flow state. So you should not try first that distal perfusion, putting the distal perfusion cannula. Just put 2 cannulas, one in the vein, one in the artery, and go to the ECMO first. And then the anticoagulation, monitor for bleeding, thrombotic complications, and await recovery. Arrest to ECMO flow time should be less than 60 minutes. That is in every trials have showed if it is less than 60 minutes, the outcome is good. Now, anticipating the risk for cardiac arrest and appreciating an evolving low cardiac output state with impaired oxygen delivery requiring acceleration of care should trigger the discussion about pre-arrest ECMO support. That is one thing that you just give ECMO before the arrest happens, rather than waiting for the cardiac arrest and deploy the ECMO with the CPR. Now, consideration for criteria for ECPR is witness cardiac arrest, initial shockable rhythm, performing good quality CPR, and not extremes of age, favorable prognostication markers, and background disease and consideration. So with that thing, I'm concluding my talk on ECPR, and then I'll give a talk on ECOR, then I'll